Hi there, this is Alan Ury, doing my presentation for the methodology class. I'm currently a paramedic for Stanley County, one of the field training officers for the shift that I'm on. I've been with the county part-time, full-time for 30 years, been in the fire service for 34 years. So I've got quite a bit of experience in the medical field. So we're going to do a medication delivery and pain management of medications that we use in Stanley County. So medication administration, always use your BSI. Use aseptic techniques when starting IVs, administer medication. Remember the 6 R's of medication administration. Very important. Dispose of all sharps in proper containers. Your 6 routes of administration is the right medication, right dose, right time, right route, right patient, right documentation. That very last one is very important, making sure you do document the exact medications you do administer to a patient in your PCRs. You sub-Q injections, use a smaller needle, you clean the site, pinch the skin where it bumps up, and you enter it at a 45-degree angle and stop insertion once under the skin. Pull back the plunger to assure that you don't have not in the vein, and then inject the medication. IM injection. Be sure to use a long enough needle to get into the muscle. Clean the site properly. Insert at a 90-degree angle. Inject and withdraw and place in the sharps. One good way to do an IM injection is a Z method. You place your hand on the shoulder or wherever you want to do it, and you want to pull the skin in the opposite in one direction. And when you enter, you inject, and when you come back out, you let go. Therefore, the medication stays in the muscle and don't seep straight back out from the puncture. Right, nebulizers. Assemble the nebulizer and place medication in the reservoir. You can remove the top of the reservoir, squirt the medication down into the reservoir, or you can just leave the top on and squirt right down the top of the opening in the top of the nebulizer. Attached oxygen is set at 8 liters per minute. At 8 liters, it gives you the proper mist for the patient to be able to inhale the medication. So, place the nebulizer mask on the face and instruct the patient to inhale as deeply as possible. Every once in a while, you have the patient inhale and hold the medication in so it can get down in the lower alveoli. Sublingual medications such as nitro, have patient lift their tongue up toward the top of the mouth, place the pill or spray directly under the tongue floor of the oral cavity. Patient vitals every 5 minutes. This is one of the very important procedures in giving medications, is knowing your patient's vitals, especially in nitro, because it will or can lower the blood pressure. The sublingual is absorbed through the mucous membranes of the oral cavity, enters directly into the systemic circulation. Transdermal administration. About the only medication we have is the nitro paste. Make sure the skin's clean at the site. Apply medication over the dosing of the patch. Your blood pressures, your systolic should be, if it's greater than 100, is 1 inch of nitro paste. Greater than 150, 1.5 inches. Greater than 200, 2 inches. Apply that normally on the upper left chest. I have a tendency to always place the date, the time, and the last blood pressure and initial. Therefore, when you're monitoring your vitals, if you do have a downward trend in your BP, you don't have to try to think back what your last blood pressure was when you applied this. With this here, it can be already there, and it's a quick reminder of what it is when you first put it on. And also when you get to the hospital, nurses and doctors really do like that, so they can keep up with it also. Non-concentrated drug vials, such as glucagon, they come in a powder or a disc form in a vial. You have to concentrate it with the saline that's in the box. Single and multi-use vials. They can be plastic containers with self-sealing rubber. Medications packaged under vacuum pressure. You must inject equal amount of air into the vial for the amount of medication you are withdrawing. So if you want to pull out 2 milliliters in a vial that has 10 milliliters of medication in it, so you would pull up 2 cc's of air or just above 2 cc's, clean the top of the vial, enter into the seal, inject your air, invert it, and then it will pull out the majority of it on its own, and you can pull the plunger back to finish filling up, and then just remove it. Ampules. Epi 1 to 1000 is usually the main ones that we have. Now we are getting the one that's got the vial that can be used, multi-use. On these, if you notice, you've got fluid up in the tip here. One of the best ways to get that out is just grab hold of the top here and just twirl it like this. With the centrifugal force, the spinning, it will drop the fluid right down inside. Take your small 4x4 and hold on the top, because normally these are going to have a very fine line cut into the bottle here, and then you just snap it. Then you take your syringe and you turn it ampoule up. The medication won't come out, and you just enter in and pull back on the plunger to pull the medication back in. IV administration. Used for fluid replacement, drug administrations, and drips come in various different sizes. The most common in the EMS field is your 10 drop set. That's a macro set. You have a 15 drop set, which is still a macro, and then you have your 60 drops. On your 60 drops is usually when you're doing a medication type infusion, such as dopamine, lidocaine drips, Levophed, things like that. Okay, on to your respiratory medications. Your albuterol. It's a bronchodilator. Indications used as bronchial dilator to control and prevent reversible airway obstruction caused by asthma or COPD. Binds to the beta receptors in the airway, smooth muscle, causing bronchodilation. Your dosage is 2.5 milligrams is what comes in the albuterol packet. You can use this as many times as paramedics. You can use this as many times as you need for opening up the bronchioles. It can also be used in line with CPAP, which works real well. One of the side effects to this is patients having increased heart rate, feel anxious. This medicine will do that. Just use caution using in cardiac disease, hypertension, diabetic, glaucoma, and seizure patients. Ipratropium, Atrovent. It's another bronchodilator. Most of the time when we use this, we use it in conjunction with albuterol to come up and do what we call dual nib. Works well with the emphysema, COPD patients, asthma. Methylprednisolone. It's another medication that we can use with respiratory. It's a steroid. Most of the time we don't see the effect of this medication. It takes a little while for it to start working, even though we do give it IV or IM, 125 milligrams. This one here, it does have its own saline up top. You just push the top down, pushes the plunger down, and it concentrates in here. And then you use it just like a multi-use vial. You just go ahead and inject. And the amount of fluid you want out, this is usually 3 cc's of fluid. Don't be afraid to use this medication with pediatrics. It does work real well. Can also give it to them IV/IM. Benadryl and histamine. We give this a majority of time for anaphylactic. Causes histamine release. And it's 25 to 50 milligrams IV, IM, IO, or PO if we have the pill version. The pediatrics the same way, but it's 1 milligram per kilogram. MAG, wonderful drug in respiratory problems. It's a smooth muscle relaxant. The route we give it is 2 grams mixed in 100 bag of saline, and we use a 10 drop set on this or 15 drop set with this administering this medication because it's over 10 minutes. pretty much you can, when you start the infusion, you turn it wide open, and it usually goes in approximately 10 minutes. On these, if you do an IV push on patients that you do give an IV medication to with MAG, if you push it rapidly, you cause respiratory or cardiac arrest. MAG is treat MAG overdoses, ventilate patients 100% oxygen, administer calcium gluconate. Seizures with pregnancies, women, 2 grams over 2 minutes. This you do push IV, and you may repeat it 1 time. It could be used to treat hypertension as well as treatment for torsades. And the route for that is 2 grams over 2 minutes. It does work well with torsades. Epi 1 to 1,000. Bronchodilator, vasopressant, works both on the beta 1 beta 2 receptors. Indications for management of anaphylactic and asthma. Used to manage the upper airway obstructions. With croup in children, dosage is 0.1 to 0.5, not to exceed 1 milligram. May repeat in 10 to 15 minutes for anaphylaxis, and every 20 minutes for 4 hours of asthma. With the croup, you can do a racemic epi. Neb is 1 milligram and 2 milliliters of saline put in the nebulizer. And in pediatrics under a month, it's sub-Q and IM. Also, on your severe respiratory patients that you may have from MAG, dual nebs, they're on CPAP, still having severe trouble, we are able to use this. Also do 0.3 to 0.5 milligrams IM on those patients, and it has worked wonderfully with that. Us at Stanley County, we do use protocols from Region I. So this is in one of our protocols for our region that we fall under their protocols. Cardiovascular medicines. Aspirin, 81 to 324 milligrams. PO. The only real precaution is a history of GI bleeding, ulcers, patients with chronic alcohol use or severe liver, or if they're allergic to it. We do have patients out there that is allergic to aspirin. Nitro. The dose is 0.3 to 0.6. May repeat 3 to 5 minutes of spray. 400 micrograms per spray in the spray bottle down here. This is what Stanley County has went back to. We did have appeals for numerous years. Only thing with nitro, you do want to keep this blood pressure above 100 when you're given this. So this up here you paste on respiratory with someone on CPAP. This package is 1 inch of nitro paste. So then again, 1 inch if the systolic is above 100, 1.5 if it's above 150 milligram of mercury, and 2 inches if it's above 200. This is their systolic. Your spray or sublingual is for angina, acute myocardial infarction. You can use the nitro paste. Once you get their pain level down to 0, you can go ahead and use your nitro paste to maintain the 0 level. Contraindications is patients who has taken ED medications in the past 24 to 48 hours. If it's given after patients that's taken that medication, it can drop their blood pressure tremendously. Use with caution with patients with inferior MI with right side involvement. This is where fluid therapy is very preferred. Use caution in patients with head trauma, cerebral hemorrhage, glaucoma, or severe liver impairment. Atropine. This is used to try to speed up the heart. Used when they're in bradycardia. It's not indicated in 3rd-degree heart blocks. So what else would be not indicated to use atropine in? Would you have a suggestion? So the other thing you don't use atropine for is heart transplant patients. Why? Because with the heart transplant patients, their vagus nerve has been cut. So therefore, the parasympathetic don't pick it up and it won't increase heart rate. So what would you have to do to these patients in severe bradycardia, in 3rd degree, and heart transplant patients? You have to pace these patients. Your dosage is 0.5 to 1 milligrams, may repeat every 3 to 5 minutes. The max of 3 milligrams. Your pediatric is 0.02 milligrams per kilogram. May repeat 1 time, max is single dose is 0.5 milligrams. Epi-1 to 10, it's adrenaline, affects beta-1, beta-2 receptors. Indications used to treatment of cardiac arrest. Stanley County, we use this in cardiac arrest as a 1 dose only in cardiac arrest. We were in a year study with this, seeing extreme good results of having ROSC in patients. Use 1 whole milligram of this in cardiac arrest. If ROSC is lost for after 20 minutes, you may administer another dose. Can be given IV, IO, sympathetic bradycardia, pulseless arrest, pediatric is 0.01 milligram per kilogram. We do continue epi every 3 to 5 minutes on pediatrics. The single dose is only adults. Adenosine. Used for converting VT. The dosage on it is 6 milligrams rapid IV push, and may repeat 12 milligrams times 2. When it says rapid push, you have to draw this one up, and once you have your IV established, preferably as closest to the heart. So if you get in the left AC with the biggest catheter you can get, takes two people really to push this. Person pushing the adenosine, they push it hard. You clamp the tube so it don't come back up in the tube of the IV. So you push the 6 milligrams real hard, and as soon as you push it, your partner pushes a flush right behind it, because it has a very short life. Pediatrics 0.1 milligrams per kilogram IV, max is 6. Cardiazem. This is another one trying to slow down the heart for AFib. It's a calcium channel blocker. 0.25 milligrams per kilogram, slow IV push. Patients greater than 60 years old is half dose. Used to manage rapid AFib, A-flutter, SVT. So, contraindications should be sick sinus, second, third degree heart block, patients with WPW. This here shows with short PR interval. Here in V2, in your V3, you have a delta wave, what they call a slurring of the Q wave. So if you have this, Cardiazem is contraindicated. But when you've got a patient that's in a rate of 180 to 200, this is very hard to determine. Lidocaine. It's used for Y complex V-tach, V-fib, pulseless V-tach. Your dosage on this is 1 to 1.5 milligrams per kilogram IVIO. Contraindications is Mohs type 2 and third degree heart block, and hypotensive. Also, lidocaine infusion rates, if you have a premix bag, it's always 2 grams in 500. And also we've had mix our own. We had to use 4 milligrams in a 100 bag, or 2 grams in the 500. This makes a 4-to-1 concentration. Your infusion rate is 2 milligrams per minute, IVIO. You can use a lidocaine clock. A lot of people are familiar with this. I never could get the concept of it until I went to a paramedic test, and when I went in, it dawned on me exactly how it worked. So, if you want 1 milligram, it's like a clock. It's 15, 30, 45, and 60. So if you want 1 milligram, you're going to have 15 drops a minute. When you're administering this medication, you won't be administering it with a 60 drop set. So therefore you have to count your 60 drops, or you have dial-a-flows in the line, so you can just set it at 15, 30. So metabolic emergencies. Calcium. Indications is calcium channel blockers, beta blockers, overdoses, mag toxicity, hypoglycemia, cardiac arrest, and renal failure patients. So you have a cardiac arrest at a dialysis center. This is probably going to be one of your medications you want to administer. Sodium bicarb, it's a buffer. IVIO, it's 1 milliequivalent per kilogram. PEDS is 0.5 milliequivalents of the 8.4. Indications of TCA overdoses, metabolic acidosis, crush injuries, cardiac arrest, and renal failure patients. Our diabetics, we currently use D10, indications of blood sugar less than 69. But if you have a patient that has diabetes, has a problem with hypoglycemia, ask them what their normal blood sugar is. You may have a patient that's got blood sugar of 100 and they're out or combative. Ask the family what their normal blood sugar is. But normally patients 69 or lower, or the meter reading low. So, and there is 25 grams of dextrose in the D10 in there. Titrate to the desired effect. D50, which is the most common that's used. I do believe we're going to be getting this back. The dosage is 12.5 to 25 grams IVIO. You can also take this to make D25 or D10. If you want D25, you pull out 25 milliliters of D50 and you pull that out and then mix in normal saline into the D50 vial and it gives you D25. So it's pushing half